Great. Hi, everybody. And I think we have a few people by Zoom. Welcome. I'm going to give an introduction to our speaker, but also give some context for the speaker series. So this is hosted by the Trauma Interest Work Group and the Mansueto Institute. The Trauma Interest Work Group was a group of concerned faculty, trainees, staff interested in the intersection of public health, trauma, and society. Our goal is to think broadly, break down silos between different fields, also involve community. There's a listserv, and I'm not going to read it. But if you want to join the listserv, try to remember that email. You can also, I'm Royce at uchicago.edu. That might be easier. Just reach out and then you can be easily added to the listserv or just email that. This series is on public safety. This is not, there are many public safety conversations across the city and on campus. This is not those. This is a different conversation, and we intentionally want it to be different. Not that the others are invalid. We talking to colleagues here, I'll highlight Robert Vargas, who has kind of flip that question around. Public safety according to who or to whom? It's whom? Whom, thank you. Public safety according to whom, which really makes the question, I think, much more interesting and potentially impactful, right? Because everybody wants safety. There's nobody who doesn't want safety. And so that's part of this series. Some housekeeping. If you're online, try to mute yourself. We're going to use the chat box for questions. Do you prefer questions to come up or wait to the end?
Probably the end.
Okay.
Yeah.
So if you need clarification, ask for it. But otherwise, let's reserve questions for the end. And I'll give a very brief introduction. So Matthew Richards has a long history here at UChicago. He did his master's graduate work, both in the School of Divinity and here at Crown School. And then worked at UCM for 10 years. No,
10 years.
10 years. Knows Hyde Park very well, knows our medical system well, for all the good and not so good things about it. And then went on to a career in public health. That's really exciting. I heard one of his talks at an event and was really impressed by how just outside the box he is at thinking about public health and mental health. So I thought it would be great for him to share some of his energy with our group. And I think I'll stop there. And I also learned that you were psychodynamically trained. So there's nothing this person hasn't done. Have you hang glided?
I have not.
There's something he has not done. Outside of that, he's done everything. Thank you.
Thank you, Bryce. Good to be with you all. So I'll just tell you a little bit more about myself. I'm a licensed clinical social worker. I do have a master's in divinity from the Divinity School. I trained here. I spent many years here. I'm the Deputy Commissioner for Behavioral Health for the city of Chicago. So I'm the city's lead on all things behavioral health, mental health, substance use, community violence intervention, healthcare for the unhoused. That's all in my portfolio at the health department. So I oversee our mental health clinics, our 911 response teams, our harm reduction portfolio. So it's direct services, work we fund, and then also all the stuff that health departments do, epidemiology, coordinating the healthcare system, et cetera. And what I'm going to talk about today is some of the work that we've done in the behavioral health space that is outside of the walls of clinics. So much of the conversation in behavioral health is about clinical interventions that are delivered in office space, traditionally defined. And so some of what I'm going to be telling you about today are examples of ways in which we've tried to move beyond that paradigm. I'm very interested in the question of trust and mistrust as a population level problem. And one of the things that we know is that there are increasingly high levels of distrust in this country towards many different types of institutional forms. forms, FORMS. Edelman, which you may be familiar with, is I think it's the largest PR company in the world, and its headquarters are in Chicago, and it does a trust index every year. It's an international trust survey. And for the last few years, in the wake of the pandemic phase of COVID, they found across sectors that trust in government was lowest when you compare government to the nonprofit sector, the business community, and the media. And I mention that because, just keep this in mind today as I'm talking, I'm very interested in how we can improve trust in government and understanding why people across the political spectrum distrust government. And there are many challenges that I could bore you with from an implementation science perspective about what makes it hard for government to show up in the ways that it needs to show up to respond to the problems that we have as a society. But I want you to think about that as I'm talking, is trying to improve the responsiveness of government to some of our most pressing challenges. And that's one of the things I'm trying to do. So I'm going to talk today mostly about substance use disorders, which is one of my primary clinical interests. So for the purposes of today, I'm going to do very brief epidemiology of substance use disorders, and specifically drug overdose in Chicago as a public health problem. And then I'm going to give you 3 examples of public health innovations that we've worked on over the last 2 to 3 years to address this crisis. And those 3 strategies I describe here, what I'm calling a data-driven naloxone access strategy. You'll hear the phrase naloxone saturation, which I'll explain what that means. Naloxone is the opioid agonist reversal agent if somebody experiences a drug overdose. Improving immediate access to evidence-based treatment for substance use disorders, and then pairing non-congregate housing with intensive on-site services for people with substance use disorders. And I'm going to give examples of all of those. So the overdose crisis in Chicago is very severe. You might know that. Over 1,400 people died of a drug overdose in 2022. I'm not showing you the 23 data because the medical examiner investigations are not quite done yet, but the data will be done probably in the next 2 to 3 months. So if you look, I'm going to try to not look behind me, even though I'm inclined to do that. Consistently the west side of the city, so Humboldt Park, North Lawndale, East and West Garfield, Austin, that part of the city is always the part that has the highest rates of drug overdose. And then sort of mid-south side, Auburn, Gresham, Chatham, Inglewood, West Inglewood, that area is sort of the second area where we have the most overdoses. Every single neighborhood in the city of Chicago, all 77 community areas have drug overdoses. 97% of those 77 neighborhoods, which is I think 75 of them, have fatal overdoses every year. But the burden of disease is not even at all across those neighborhoods. And you see the darker shading in the communities that I mentioned. More people die of drug overdoses every year in Chicago than gun homicide and vehicular fatality combined. If you think about the relative amount of attention paid to this problem versus, say, gun violence, there's a notable difference. We don't really talk, there is public discussion about this problem, but not as much as one would think. And that's worth reflecting on why, which I have many opinions about, which we can talk about if you want. What we have seen in Chicago, which is a little bit different than other major American cities, is over the last year or two, we've started to see a leveling off in our fatality count. It's not sloping down yet. And public health people are always only cautiously optimistic, never more than that. And that's how I would characterize my emotional posture related to it. We'll see what the 2023 data looks like. But other cities, other major American cities, mostly are just continuing to see the curve slope up. So in the spirit of being strengths-based, which is one of the cardinal values of social work, I do want to think about what are we doing well and not just what is the problem. So the first thing I want to talk about is naloxone access. This is a picture of Mayor Johnson. I'm going to talk about what we call public health vending machines, which is something we started in October, and the mayor joined us at our social services center in East Garfield Park to debut this program, and he was the first person to vend harm reduction supplies out of the machine. So when I talk about Narcan or naloxone, is the generic name, access, I'm talking about ways that we can increase access, particularly to community members, to this medication. Because we know from a few different studies that have been done that as you increase naloxone access in the community, you see measurable reductions in drug overdose, particularly if you are getting the medication in the hands of lay people who have proximity to the highest risk networks for drug overdose. And so something about 2 years ago that we set out to do was developing a more coordinated strategy for getting this medication into the hands of community members and not just in the hands of, say, medical professionals and first responders, which is often where the medication is primarily held. The federal government has developed plans where every state now is expected to have a Narcan distribution strategy. We have 100,000 people a year now dying of drug overdoses. So it's an astounding problem. And the expectation is that you have a Narcan saturation strategy. And I'll explain more what that means in a minute. One of the interesting questions related to that strategy is how do you actually quantify and measure the amount of Narcan that should be available in a community? How do you actually define that? And I'll talk a little bit about some of the work that we're doing to try to do that. So we debuted a couple ways initially of trying to get Narcan out into neighborhoods. The first thing was we thought, what public systems do we have that are in every single neighborhood in the city that people trust, that people will actually walk into? And one of the things was libraries. We have 81 libraries in Chicago's 77 neighborhoods. And so the first thing that we did was we did a phased implementation of pushing naloxone out in 3 phases across that system based on the severity of the problem in the neighborhoods in which those libraries were located. We trained 700 public librarians on the use of the medication, mostly not because of the expectation that they would use it, though they might, more to explain it to community members when community members had questions. And we put naloxone boxes in every single one of those 81 libraries. And what we've seen so far is that we've delivered almost, I think it was 30,000, almost 16,000 units through this program. It's been our most effective way of getting naloxone into the community, has been through the public library system. So this is one of the vehicles that we were using to get it out into communities. We also put it in a bunch of aldermanic offices. It's in all of our mental health clinics. It's in a number of other public facilities. We've worked with the Independent Music Venues League, so live music events. Lollapalooza is probably our biggest event of the year that we just saturate with Narcan. Large conferences and events, International Men of Leather, other events where we've seen overdoses, we try to get Narcan out. And then we developed a bit.ly Find Narcan Near You website that we post out frequently across social media. We also wanted to do something a little bit more targeted, which was we wanted to get Narcan and harm reduction supplies into the hands of street outreach workers that work in the communities that are most impacted by this problem. So what we do is we do basically monthly heat mapping. We create these hyperlocal maps, which you see behind me, which show the overdose patterns from the preceding month, but what they also show is the staffing patterns of the street outreach organizations. And what we're trying to do there is we're trying to show day and time of overdose patterns against day and time of staffing patterns, so that you can try to start, our street outreach organizations can align their staffing models and with the overdose patterns that we're seeing. If we're seeing high volume of overdoses in a particular string of blocks, typically on the weekend, and it's between 11 p.m. and 4 a.m., we want to try to make sure that we have people on the block there with these supplies. So the first strategy is more of a universal strategy. This is more of a targeted strategy for a workforce that is in our highest density locations. We then started thinking about this idea of vending machines. So people started talking about this, I would say, and I started to hear people talk more about it, I want to say in 2019, because in rural locations where there wasn't a lot of access to these supplies, people like, for instance, in the Nevada desert, bought these machines and they would put them in these public locations. And it was a way that for folks who weren't interacting with harm reduction organizations or whatever could access these supplies. So we decided to procure a group of these machines. Now, of course, it took, I think in city government, somewhere between 2 and 3 years to complete the procurement, which is a good example of what I mean by some of the things in implementation science that don't feel, perhaps don't feel worth studying, but that was a painful process. But now it is done. And we started with 5 machines, which probably sounds like a small number. It is a small number, in October of last year. And we pushed these out in particular high density locations. So we looked at overdose patterns. We looked at locations that were either public locations like a train station or a library, or places that were otherwise sort of open and accessible to the public. Like we have a triage center in Roseland that's operated by a substance use provider organization. And then what we did, you see the locations that we chose, was we decided to not just put naloxone and like things like fentanyl and xylazine test strips. Those are things you can use to test for the presence of particular analogs in your drugs that would put you at higher risk of having a drug overdose. We chose to put basic supplies in these machines too. And some people didn't really understand that. They were like, that's kind of a feel-good thing to give people hygiene supplies or socks or whatever, but like really what's the public health benefit of that? And our response to that was 2 things. One, we're trying to promote overall health and well-being and emphasizing that caring for oneself related to your substance use is part of your overall wellness. And if people's more basic needs are not being met, it's hard to engage with thinking about your substance use. So part of that was it's promoting it's destigmatization, it's trying to promote a more holistic sense of health. But the second thing was we had a suspicion that unhoused people, we knew this from different research that I could talk about, that unhoused people were much more likely, particularly if you sleep outside or sleep on the train, to have a substance use disorder than the general public. And go back to my point at the beginning, we're trying to get naloxone into the hands of people that are most likely to witness an overdose or have an overdose yourself. And so we really saw this as a way of engaging with the unhoused population. And so you see on the right-hand side, the supplies that have been vended so far. You get an individual ID through this machine. If you just want Narcan, you just press 1, 2, 3, and you can get Narcan. You don't have to get an individual ID, but we have a QR code. If you have a smartphone, you can get an ID number, and then that gives you the ability to vend items for free out of this machine. And it's all cloud-based data storage. So we're able to look at patterns of what's being used, what's not being used. It's all de-identified data. But we also have a survey. And so the survey data has been useful because we have found for over 1,000 people that have completed this survey, 19% have experienced an overdose themselves, 44% have witnessed an overdose. Again, we're trying to get this medication into the hands of people that are most proximate to an overdose event. So that's actually the part that is, I think, most encouraging for us. We are about to start scaling this project. So I want, I guess I can't say don't quote me because I'm being recorded. I would really like 100 of these across the city. So in government, sometimes, I will sort of joke, throw a rock and you'll hit a pilot project. People love to do pilot projects. I'm all for pilot projects, but I'm not for pilot projects that go nowhere. So for me, this is a pilot project. We're learning, and I think it's getting to the right people. That's the preliminary data. Now we need to start scaling it more. And it's going to be one of the inputs into our harm reduction saturation analysis, which I'll talk about in a minute. So what we're doing right now, and I wish I had the results, I don't, because we're designing the methodology for how we're going to do this analysis right now. But, one thing we do know is that when you rely on vending of Narcan from pharmacies, that is a very high barrier way to get this medication. It's now over the counter, which is good, but the problem with that is the cost. So if you buy a box of this, it's like, I think it's about $40. So for a lot of the folks we're concerned about, people are not good, that's a real barrier to pay $40 for this medication. So while I'm all for not requiring a prescription for this, I don't see the costing of it and the monetization of it as, I think that's a different type of barrier. So, what we've seen with naloxone dispensing rates is you see it's 0.3 per 100 people in Illinois in 2022. And then what we looked at was, we looked at what our Narcan availability rate was in the city of Chicago, and it was more than double that in 2022 and 2023. So we want that number to continue to increase while we are doing an analysis. It's going to be like a time point, study that people who have PhDs, which I do not have, will design that study and are designing it right now to look at, can we quantify the difference that it's making in the neighborhoods that we're working in? So this is one of the big things we are working on, is trying to quantify the amount of Narcan or naloxone that you need to have available in a community relative to the scope of the problem in that community. And how do you then measure that? So some of it is going to be looking at the amount of naloxone that we're distributing through these different inputs, the vending machines, the libraries, our street outreach workers. We're also going to include wastewater surveillance data, which I don't know if folks have talked about wastewater analysis. It's very commonly used in monitoring infectious diseases, but because people, of course, will excrete the naloxone through their urine and it'll get into the wastewater system, we're trying to look at, is that also a way that we can measure the amount of people that are actually administering the drug who don't die. So we're looking at that right now. So a second strategy is increasing access to high quality evidence-based treatment. And one thing I'm going to talk about is medication-assisted recovery. That's the primary thing I'm going to focus on. So you might know that there are FDA-approved medications that treat opioid use disorder. So these are medications that reduce the risk of overdose. They address withdrawal symptoms. A couple of them, naltrexone particularly, helps with cravings. There's a whole class of these that also help with alcohol use disorder. They are massively underprescribed. Only about 10% of people with substance use disorders get offered these meds, and there's a racialized differential there too. People of color, particularly Black people, are underprescribed these meds. So one of the things we're really focused on is trying to improve uptake of these medications. Something interesting, something I say to my team in government is never put a crisis to waste. Crisis in government is a chance to get around the way we normally do things. And I think that's true in any organization. Crisis is challenging, but it is also an opportunity. And that was true in COVID. The government had to waive, or didn't have to, it chose to, waive some of these requirements that had required that you had to meet with a provider in person to get access to these meds. And so because of quote unquote social distancing, because of disruptions in the healthcare system, the government, by which I mean the DEA, SAMHSA, waived that requirement. And I'll talk about that in a second. These were some of the things, the flexibilities we got, that you could prescribe buprenorphine, which is one of the meds, through an audio-only telemedicine encounter. So you didn't even need to have the visual, which was helpful because for folks who don't have phones that would facilitate that, that was important. You did not have to meet with a provider in person for bup. You could use non-compliant, HIPAA-compliant platforms. And this was really important, that you could take home up to 28 days of methadone for stable patients. That was previously, you had to be on methadone for 9 months before you could get a 28-day supply. So really high barrier. So these changes occurred during COVID, and we chose to take advantage of them. So what we did was we created this program called MAR Now. This was trying to bring what we were seeing in the science forward, which is that it's safe to teleprescribe these meds. The state has a 24/7 Illinois opioid helpline. So we funded the state to embed prescribers into that helpline so that if you wanted to get these meds, you could just be assessed for these meds and prescribe these meds over the phone. And at no cost. Like if you had insurance, we would prescribe it to your local pharmacy and you could pick it up. If you couldn't pick it up, we would bring it to you. And what we've seen so far is, I'll show you the data on this in a second. We had between May of 22 and August of 23, I'm updating this data right now, we had 885 people call for opioid use disorder treatment. And here you see some of the initial results that we haven't, there's a paper we're publishing about this right now. You see on the bottom, some of the outcomes related to attending first appointment for your methadone, buprenorphine patients connected to the medication, 99%. So 286 patients who we prescribed bup over the phone, 99% of them got connected to meds. You see some of the other things, withdrawal management and medical stabilization. You see on the top the different types of things that people were seeking. This one in the middle is kind of the most important one, which is that 247 patients started their buprenorphine in the community, and then were of those, 95% were connected to a provider for ongoing treatment. The biggest thing, there is two types of criticisms that you hear of this type of program. One is extreme anxiety that we are making these medications too easily available to people without doing our due diligence, doing a comprehensive physical, etc. It's not safe. That's the biggest thing that we hear. The second thing that we hear is, okay, so if you prescribe people these meds, well, that's great, but it's only for 14 days. So what happens after that? Well, what happens after that is people get connected to a provider, and our data shows that that's what happens. The problem, so that settles the second criticism. The problem with the first criticism is that it imagines a universe that no one lives in. I like to say I deal with reality as it is, and the reality that I live in is that a lot of our patients that we're most worried about will not access these medications if they have to walk into a medical clinic and get the run over by a medical provider who may or may not shame them about the fact that they have a substance use disorder and might make them feel like garbage. So instead, what I'm going to do is I'm going to say, we want to make it as easy for you to get these meds as it is to buy street heroin. That's my goal. And no shame, and try to get you connected to these meds. We'll bring them to you, we'll pay for them. And if you have a dignified experience with that encounter where you're treated like a human being, maybe you will be more likely to stay engaged with us over time. And I think we believe this is the largest data set for home induction of patients in the United States, which is why we're rushing to get this paper out, because we think it shows and settles the question of the safety of this approach. We also have been trying to create single entry portals into treatment. We make it way too hard to get into treatment. You may be familiar that Oregon decriminalized certain types of substances, and then those substances were just recriminalized because people were seeing concerning trends in the overdose data. And that experiment, if you want to call it that, was given 2 years. The problem is the history of the war on drugs was a 60-year project. A 2-year project in the other direction is not enough time to show the value of it. But if you look at countries like Portugal, which have had a history of decriminalizing substances, one of the things that they have been really adamant about is immediate access to low barrier treatment. That we need to have no wrong doors. So if we have street outreach workers that are engaging with a person can call a number and we come and pick you up and we get you into treatment same day. We can prescribe you methadone or buprenorphine out in the field and get you started. Our system does a lot of gatekeeping around substance use disorder treatment and makes it really, really hard for people to get started. And so when you're decriminalizing substances, if you're not similarly making it much easier to get into treatment, it's not surprising to me, frankly, that we don't see benefits at the population level. So this is an example of my team created an API. So it's a data set that we update regularly of all the safety net providers by neighborhood. We maintain the data set ourselves. and then it feeds through a resource finder. You see the address. Our 211 system has it. Our 988 system, which is the 3-digit federal mental health helpline, has it. 211 is the city's like human and social service hub. So they all have this data too. So I'm going to tell you about, I want to make sure we have time for questions. How am I doing on time here? Okay, I'll go fast. So this is a third project. So one of the things that we consistently see is that if you look at people who sleep outside, by which I mean train, parks, under bridges, in airports, I don't mean shelters, you see very high rates of substance use disorder. About 2/3 of people have substance use disorders. That is not often talked about as openly as it should be. And I think the reason it's not is because there's a well-intentioned notion that we don't want to stigmatize people who are unhoused. But that proceeds from the notion that there's something shameful about having a substance use disorder, which there's not. There's nothing to be ashamed of about that. That is, I understand substance use disorders to fundamentally be a trauma-based condition that is really about a person's to self-regulate and feel safe in their own body, in the context around them. Could be because of abusive developmental experiences they have. It could be because they don't feel safe in their neighborhood or safe in a relationship. It's really an attempt to self-regulate and restore equilibrium. And because there's nothing to be ashamed of about substance use disorders, we should talk openly about the fact that if you have a severe substance use disorder, you are more likely to become homeless or be homeless. And being homeless itself might make you more at risk of developing a substance use disorder because being unhoused is very stressful and scary. So one of the things that we're trying to do, and we did it during COVID, go back to my point about crisis can be opportunity, is that we were really concerned that unhoused people, in this case, it was in shelters, who had complex health conditions would be very at high rate of dying if they acquired COVID. Those are congregate settings. So disease transmission was happening very readily in shelters. And then unhoused folks have much more higher chronic disease burden than the average population. So we knew they were going to be at much higher risk of death or medical complication if they got COVID. So we did this shielding housing project. That's what we called it. So we screened people across the shelter system. And if you were at high risk of a negative outcome, we offered you diversion into hotel housing downtown. And I included on the next slide the paper that was written about it in JAMA. Liz Tong, who's a professor here, actually helped do the data analysis for this project. And I included the Tribune headline for this project, which was, during pandemic, swanky Gold Host Hotel has become a haven for people living on the street and others at risk. Housing is healthcare. This was one of those lovely examples of capitalism turned upside down, where fancy hotels that the types of folks we work with who never are able to stay in, stayed in these hotels because there was no customer base for these hotels during the early part of COVID, which I loved. I didn't love that they didn't have a customer base. I loved that our people got treated with dignity. And so what we did was folks stayed in this project for about 6 months, and then we had on-site healthcare providers. Lawndale Christian Health Center was the lead healthcare provider organization. So primary care, addiction medicine, psychiatry, peer recovery specialists, case managers, nursing staff. And so you had your own room, 3 meals a day, there's a roof so you can get sun, all that. And then, all the healthcare. A lot of folks had never really had a primary care provider before. And then this paper basically studied the outcome, which was we didn't have a single patient die of COVID. We only had 6 patients who needed to be ventilated. So there was statistically significant reduction in COVID morbidity mortality. I didn't show the regressions and stuff. I know I'm at U of C, so I probably should show the regressions, but you guys I'll send you the paper later. And then it was interesting because it showed measurable improvement in blood pressure, blood sugar control, and patients who had complex behavioral health conditions started treatments they hadn't been offered before. For folks that have like a psychosis spectrum disorder, starting long-acting injectable medication. For folks who have a substance use disorder, starting buprenorphine or methadone, et cetera. So we said this needs to become a permanent thing. The city needs to move this forward. So we started thinking, I'm gonna move through this part quickly. We started thinking about a group of folks that cycle across our systems a lot who are unhoused. And there was a paper called the Roadmap Initiative, University of Chicago Health Lab helped on this. You might notice there's a lot of U of C people involved with my projects. I think that's what 12 years down here does. And what we did was we looked at folks that were cycling across the unhoused system, the jail system, and across the emergency department system. And we looked at their health presentation. And you see the cycling patterns here. There was about 1,200 people that were described in this paper as multi-system high users. And I'm not going to walk you through everything on this slide, but there were 3 cohorts of people. The short version of the story is that middle-aged males who are unhoused with complex health conditions and behavioral health conditions were the biggest cyclers. There was a small group of a younger cohort, which was different, and younger cohort in families. And so some of the key takeaways when we looked at this was it's a relatively small population that are cycling in this way. When you think about a city with 2.7 million people, there was $300 million in spend associated with the cycling pattern. So when people say things like emergency department care and incarceration are expensive, this is what we mean. Even though I think the arguments about incarceration are not just financial. You see from a race equity perspective, this is very disproportionately impacting Black people, specifically Black men who are over the age of 45. And behavioral health was right at the center of it. So what we decided to do was take what we learned from that hotel project downtown, take the model of non-congregate housing plus intensive on-site services and focus it on this group of folks, the 1,200. And the model is, I'll show you in a second, we started with this building, which if you've ever driven north on Lincoln, like through Lincoln Square, up almost into Skokie, there's all these California style motels. If you're from California, you might feel like you're at home. There's like 15 of them if you drive up Lincoln. But many of them over the years have basically become part of the affordable housing system or not affordable housing system. So a lot of unhoused people live in these buildings. It's sort of crisis housing, if you will, for a lot of folks. This particular one, was up for sale. And so I and a couple other people convinced Mayor Lightfoot and then Mayor Johnson that we should buy this building. And thankfully they said yes. And so what we did was we then retained Gensler, the architectural firm, they're doing a trauma-informed redesign of this building. So if you look at this building, I mean, there is like a mural on the side, but it needs work. Let's just put it that way. So the redesign looks like this. So we're tearing apart the parking lot, creating a garden outside. There's a lot of money going into the redesign of the building. We've selected the human service partner who's operating the project, and then there's going to be an interdisciplinary healthcare team that staffs the project. It's about 40 units if you go back to the delivery model. What happens a lot with this population is that people are either offered housing with no services or they're offered services with no housing. So what I mean by that is getting folks into permanent supportive housing and saying, here's the key to your apartment. I'm all for people having housing. I think everyone should have housing. In my view, housing is a human right. But if you have schizoaffective disorder, housing does probably reduce your stress levels, though that's actually not a simple calculation either. It doesn't change the fact that you have schizoaffective disorder, right? It might reduce your stress levels, which might then reduce, like I'm looking at Dr. Lee, he can keep me honest here. So you might be slightly less symptomatic, but it's not going to resolve the fact that you have schizoaffective disorder. So I think that model that fits a lot of people. It doesn't really fit what I call my people. These are my people. And so the converse problem is we will fund these mental health teams to try to engage people who are sleeping on Lower Wacker Drive, but then we never have housing. So it's like you're living in this incredibly stressful set of circumstances and we're saying, hey, do you want to see a psychiatrist? Hey, Dr. Lee and I love Dr. Lee, can prescribe you a long-acting injectable off of this van. I don't know you. Like, I don't know where I'm gonna get my, right? So both of those models are wrong, in my opinion. So what we're trying to do with this project is do both. We're trying to do communal living, which is non-congregate, which is paired with intensive on-site services. And what we're going to be looking at is the impact of the intervention on utilization of other services and on health outcomes, with the goal of successful transitioning into permanent supportive housing when you leave the project, and longitudinally following people to look at the outcome. This project is due to start taking patients late this year, early next year, so I don't have any data for you yet on it. But we've worked, the city is finalizing our purchase of this building within the next 30 days. And there's a huge amount of work that went into getting us to that point. So that's what I have for you. Those are 3 examples of innovation. Because I'm at U of C, I'll say the thing that I miss most about being at U of C is having time for sustained reflection. My day is basically putting out fires every day that are unplanned. And I miss that. And so I say that to you to say, there are so many people in this city, in DC, in a lot of centers of influence that started here. And sometimes when you're here, you might feel like, gosh, this feels really far from the end product that I'm moving towards. This place changed my life in terms of, with all its imperfections, which I am very aware of. But it made me a much more critical thinker. And a lot of the work that we've done here, I think, is because of some of the skills that I and others learned at this place. So I just wanted to make that local connection, and happy to take questions. So thank you. Yeah.
Hi there.
Hi.
I am currently a prom student.
Yeah.
And I'm completing my practicum with CPS. And they recently had us complete like a training on how to administer Narcan.
Yep.
These are like rolling it out to all the high schools already, and then the elementary schools by the end of the year.
Yeah.
I'm wondering if that is also part of like the analysis y'all are doing on like uptake and use of Narcan, or if CPS is presumably going to do their own.
Yeah, so that's a great question, and thank you for asking it. So we've helped CPS on the implementation side of that, purchasing the Narcan and helping provide some subject matter expertise, but they are accountable for the rollout of it. It's basically, there are certain required medications that schools have to have on site, like an EpiPen, for instance, for folks that would have an anaphylactic reaction, and Narcan has become one of those medications. And so that, which I fully support it being one of them. So CPS is overseeing the implementation. Having said that, I'm glad you actually asked that question, because I don't know that we have thought about including that input in our analysis. And I think it actually would be a good one to include. There's a lot of concern about drug overdose patterns among young people. So I think it's a great point. So thanks.
I mean, if I can just
Yeah.
add something, that when you were talking, it just kind of made me think about like, because I used to work for LA Unified, and they had a similar approach where we start with the older kids and then move to the younger kids.
Yeah.
Which I think makes sense, but like what you were saying about like targeting certain communities, like did it make sense to maybe like first offer it in certain high schools versus like because from my understanding, I'm currently at college prep in
Yep.
Kenwood, and I believe we got it like way after we were supposed to. So just kind of like thinking about how we can target communities that might not have as much.
Yeah, I mean, I can tell you the way that when we're doing like big system implementation, the health department always does phased, where you start in most impacted and move out from there. So like that's the way we did, as I mentioned, the Chicago Public Library implementation. We're doing a thing I've been working on the last 3 years, is incorporating mental health professionals into the 911 system. So if you have a mental health emergency, you're met by a behavioral health team rather than a primarily police-based response. Same thing there, started in communities with the most mental health emergencies. So I don't know if that's the way that CPS is approaching it. I can ask, but that's a good question. And that is the way we do it at the health department. Yeah.
So for your mental health centers, I went online and I just like looked at them and looked at the addresses.
Yep.
Do you have any plans to kind of expand the one in Inglewood to include like Spanish speaking clinicians and also like
Yep.
resources? 'Cause
Yep.
that's pretty heavily, it's turning into a heavily Hispanic community in like the surrounding areas. Because one thing where we talk about like the Latino population, it's one thing to have like Spanish speaking like clinicians and workers, but there also kind of is like an element too of like culturally competent.
Totally. So thank you for that question. I didn't talk as much really at all about our mental health programs today. So we have 5 mental health clinics, as you said, the city. I can talk about the broader system. We're in the process of opening 2 more this year. So Mayor Johnson, that was a key campaign commitment that he made. And he's talked about the importance of that. And so I'm helping support him and his team in getting that done this year. So we're doing 2 more this year. So we should have 7 by the end of this year. I think there will be more that we open in subsequent years. I would say our biggest hiring priority, and there are many, is hiring clinicians who have diverse cultural identities, starting with folks that are Spanish speaking and can deliver Spanish speaking culturally responsive services. Of all the folks on our team that have wait lists, that is the team that has the longest wait lists. So right now, 3 of our sites, I would say, have more of a specialty in Spanish speaking culturally responsive services, and Inglewood is not one of them, to your question. So what we are looking at doing is, as we're doing that recruitment, is going to be hiring more Spanish speaking providers and who can deliver culturally responsive services across sites. Same thing with Chinese speaking, Polish speaking, Arabic speaking. Given the international scope of the city, we need to be able to deliver services that are culturally and linguistically responsive. So that's the reality is, though, we have a workforce shortage. So it's a hiring challenge every single time to get the people that we need, but we're working hard on it. So I appreciate you raising it. Yeah.
So for the individuals that were housed in those
Yeah.
hotels, after the epidemic ended, so, and you say with this one, duration is usually about 6 to 8 months. So how do you guys determine like when that cutoff is and what happens to them?
That's a great question. So
Yeah.
that in the paper, we show the housing data. And I say we, I did not write that paper. It just feels like it's so shaped my thinking. The folks who wrote that paper outlined the housing outcomes in the paper, but the idea for this project is we've been calling it stabilization housing. So it's not intended to be it's not permanent supportive. It's a really high touch, high cost model. So the idea is it's a good fit for somebody that's in crisis, that's really not stable, that's probably not going to be effective initially, I should say successful in a permanent supportive housing solution. Our goal is that most folks will achieve stabilization within about 6 months, but we don't have to, like, it's always a person-centered approach, right? If you're not ready at 6 months, then it's not 6 months. It's whatever it needs to be for you in order for us to get you ready for the next step. So what are the next steps? Rapid rehousing, permanent supportive housing, residential treatment for folks that need long-term residential support. For some folks, it's family reunification if there was like ruptures in their living situation due to their health conditions. There are some people that needed to be in skilled nursing facilities because they had terminal illnesses that hadn't been diagnosed. Specialized mental health rehabilitation facilities. So it's a completely individualized pathway for each person. Yeah. Yes, sir.
That was a great talk. Thank you for sharing. I have a lot of questions, but maybe the one to bring up first, especially given like interest in the audience and the topic inherently and future career in this area.
Yes.
Tell us, I saw a talk by Dr. Arwadi about how she managed her team during the pandemic. It was just so amazing.
Yeah.
That nobody quit.
Yes.
She managed to get them all through it.
Yes.
And so you have pretty busy days. I'm guessing your team is kind of biggish. Tell us
Yeah.
about that. What is that like, working in a team for the city on these initiatives?
Yeah, that's a great question. Yeah, Dr. Arwady and Dr. Ige are both very special leaders. And I feel lucky to work for and to have learned from both of those women. I think that at the health department, we are used to doing a lot with a little. We are the most systemically underfunded major American health department in the United States. That is a fact. We are 95% grant funded. And so most of our teams are people where it is deep missional life work that you have chosen to do this work, right? You don't work in government unless it is your passion to do so, because frankly, it's very challenging. And so I think with my team is about 150 people. There's a deep sense of mission. And I think that partially sustains us. I think practically speaking, one of the biggest problems, biggest challenges for me, and I don't think I've done a great job of it, to be honest, is trying to keep our hiring at pace with our mission. Because I think one of the things that can happen if you've ever worked for somebody that says yes to everything, I am that awful person. I say yes mostly to everything because I like to lead with yes.
So your team says you're insane.
Yeah, my partner has given me the feedback that I create probably a lot of stress for other people, including myself, and I think that's accurate. So I'm trying to have better boundaries, but in government, sometimes people lead with no. That's a very common resource rationing strategy to protect yourself. Is you come in with a new idea and people are like, oh, we've done this for 20 years and that's not the way we do it. Well, that's a horrible reason. Saying we've done it some way forever is a horrible reason to defend doing something in a particular way. So I think that is a very practical thing I would say for any of you as leaders is making sure as you're thinking about the scope of what you want to do, that you're trying to keep up with the resourcing. Because in the public sector, particularly, the resourcing part takes a really long time. It's very bureaucratic. So I think I would say mission, parity between pursuing that mission and your resources to do so, and social connection on your team.
One thing that emerged, thank you. One thing that emerges that I'm shocked by is you left academia, and if I understand correctly, you're writing more grants.
So it's interesting. We are a uniquely grant dependent department. The exception to that, though, is my stuff. Why is that? Because my stuff gets a lot of public focus, which is mental health, substance use, violence, homelessness. Those are like if you took a poll of American mayors and said, what are the 5 issues that keep you up at night? At least 3 of those would be on their top 5 list. The challenge is there are critical functions that the health department performs that, if you know about the prevention paradox, that are sort of buried and people don't notice. So this is where our political scientist friends are helpful, right? Who makes sure that when you go to a restaurant, that the food is safe, right? We have environmentalists, we have food sanitation inspectors. When you think about air quality, we have environmental inspectors, right, around the city. When there's a disease outbreak, our team is in the midst of a measles response right now, right? And supporting the health of new folks who are arriving here from other places. Those are all missions that we have to stretch and respond to. And so that's where I do worry, not just for Chicago, but any city. Coming out of COVID, we have to increase our funding in public health in this country. We grossly underspend on public health and we spend tons of money on healthcare. And yet our life expectancy rates are very low relative to our companion countries. And I know you all already know that. It just does not, that insight, which is puff puff at the University of Chicago, no, it doesn't translate over into political reality yet. And so that's a thing I worry about.
Those are all the theme of the year, public safety, right? So everything you just mentioned, the routine things we come to expect and probably take for granted about public health.
That's right. And with public safety, Superintendent Snelling talks about this regularly, that Chicago has over-relied on policing. When you look at the amount of money that we spend on policing, the amount of policing per capita in this city, it's much higher than the cities we compare ourselves to. But when you look at a fatality curve for homicide in LA and New York over the last 30 years, what you'll see for LA and New York in terms of their homicide rate is that. What you see for Chicago is basically that. They've declined 80 to 90%. We've declined 10%. Why? Because they don't rely singularly on policing in the way that we do. And they've made investments in other types of safety promotion interventions. This is one of them. The research on access to substance use disorder treatment, reducing and improving safety in communities is highly well validated. So you have to have holistic frameworks for thinking about safety. And for my work, when people live in neighborhoods that are less safe, it increases your risk of having traumatic stress response, which increases your risk of using substances, relying on substances to self-regulate, which is utterly understandable and not surprising. I would do the exact same thing. Yes, ma'am.
On the heat mapping.
Yes, ma'am.
Was this taken at one point in time? So I know throughout your presentation, you mentioned the data set that you all have.
Yeah.
Was it created from that? And was it created based on one time point?
Yeah, so that's a great question. So when I started, which was in 2019, one of the things that our West Side providers told us was, we really need hyper-local maps, by which they meant basically neighborhood level maps where you could see street intersections. Because it's not really helpful from an intervention perspective to just be told, we had 50 overdoses in Inglewood. Well, where in Inglewood? At what time? Right, et cetera, et cetera. So what we do now is we take the data from the prior month, which is our EMS data. So it shows you when an ambulance is dispatched to reverse someone. We take that data monthly. We're starting to think about another system called ODMAP, which conceivably can include overdose reversals that community members do too, because that data doesn't fit into our model right now. It's not monitored in the same way. And then we're able to also map the service provider data, as I mentioned. One of the things that Dr. Ige, who's my boss, likes to say is, and Dr. Arwady would say something sort of similar, which is she does not like to admire problems, right? There's sometimes in public health, like visualizing the same problem over and over is a little bit like trauma dumping. It's like everyone knows this is a problem. Like I don't need to be told the same thing over and over. What are you going to do about it? And so that's one of the things we're trying to do with this is we're not going to just sit here and admire this problem and create maps. We want to know like, okay, this is what it looked like this month. What can we do to save lives here? How much more money do you need in order to do it? So that's the data. It's monthly EMS data, and I'm interested in including community member data too, but we haven't quite figured it out. Yes, sir.
First of all, thank you so much for your work.
Sure.
Try to keep this short. But I'm interested in the stigma around mental health.
Yes.
Maybe on a broader level than just Chicago.
Yeah.
But especially recent administrations. Why is the city doing anything to address like Smurfs? Because I've been in one for a year and 9 months and 2 weeks, across from Lincoln Park Zoo. And I've now I'm a member of Thresholds.
Good.
But they're mostly very neglectful and very abusive situations I've been in. There's absolutely, like you said, good, sir, that's your response. But honestly, I want to move out of Chicago and maybe in this country because these are some of the most neglectful, abusive situations I personally ever been in. Those are the cultures within these situations. How can we address that?
Well, thank you first for sharing your story, and I'm sorry that that has been your experience. I think that there's a few things I would say about that. So I think one is, I like to use the phrase system of care. We haven't in this country, we have made a paltry investment in the community behavioral health system of care. So in 1963, sorry, I'm doing a little history and then I'm gonna get to your specific thing because it's related. When President Kennedy signed the Community Mental Health Centers Act in 1963, which is the last thing he signed before he was assassinated, the vision was, we're taking people out of psychiatric hospitals and they are able to live in the community, get services, free services in the community, have housing, and live with dignity in the community, because literally almost like 1 in 200 Americans was living in an institutional setting in 1960, which is staggering when you think about that. But when you think about American history, maybe not. So that was the idea. But the problem was political timelines change, right? Administrations change. So President Kennedy was committed to it. President Johnson was committed to it. President Carter was committed to it. President Reagan was not committed to it. And so it got turned into a block grant program. And what ended up happening was a bunch of the clinics that were being opened around the United States, we were going to open 2,000. We only ended up opening 1,000. And then of those 1,000, a bunch of them then closed because there was no reliable funding stream. I think a second thing that happened was we didn't really imagine a holistic system. There was this idea that if you have, I'm going to make up, if you have, let's say, a schizophrenia spectrum disorder, that long-acting injectable or so-called antipsychotic medication was going to be this panacea. And it isn't. For anyone that's ever been on one of those medications, they are often very helpful, but it is not a panacea. And so what we have to invest in is an accessible community behavioral health system that provides housing, that provides primary care, high quality psychiatric care and psychotherapy, peer services, where it's all embedded together. And we need to fund that system as a permanent national priority. And I think what happens is when that is a resource limited system, the staff develops secondary trauma. And if you have had secondary trauma symptoms, and I say this as a LCSW who still does some direct services, when my fuse is short, when my trauma history comes up, I am not able to treat the people that I work with, Dr. Lee and I were just talking about this before we started, with the dignity that they deserve. And so if you've had interactions that have felt undignified, I would wonder the extent to which that's a reflection of the work, the strain that it takes on the workforce and the ability for people to show up in the way that they need to show up. And that's not an excuse, by the way, it's context. So I think that's what I would start to say, is the funding is one thing, how it affects the workforce and then how it affects the clients is the downstream of starving that system, is people have stories like the story you just told.
Okay, well, thank you. Are you gonna be able to stick around?
Yeah, I can stick around for a bit. Yeah.
Use that.
Yeah, thank you.
Thank you so much.
Appreciate it.